So HIV exposure to penile tissues is the primary route of infection for heterosexual men, but is also a route of infection for MSM who practice insertive intercourse. Current prevention tools for men include condoms, medical male circumcision, and daily oral PrEP. However, these methods are imperfect for biological and behavioral reasons, and continued research is being performed to improve each of these methods. While research continues to be developed for new interventions, penile drug exposure remains understudied. Data regarding ARV exposure in penile tissues is extremely limited, and typically most studies of ARVs at mucosal sites of virus exposure use vaginal or rectal tissue biopsies or swabs of mucosal surfaces. However, there's a lack of appropriate tissues available for the penile compartment to perform many studies. One study, conducted by Julie Fox and colleagues, evaluated the CCR5 antagonist maraviroc in urethral fluid and found that maraviroc exposure was over 100 times greater in urethral fluid than in plasma. However, these findings have not been extended to other drugs or drug classes. In studies conducted by our branch here at CDC, we've begun to evaluate the ability of new PrEP modalities to protect non-human primates from penile exposure to SHIP. One example of this is a study published earlier this year of long-acting cabotegravir, which showed that cabotegravir penetrates penile tissues as well as fluids, but it also provides protection from penile SHIV exposure. In this study, we sought to evaluate ARV exposure in the male genital tract. We examined ARVs on the urethral and gland surface using swabs that were collected from men receiving ARVs in a study that explores potential event-driven PrEP, or ED PrEP, or post-exposure prophylaxis, PAP, dosing modalities. We used specimens collected from this study to help gain an understanding of drug distribution for multiple classes of ARVs, and we sought to compare penile drug distribution to those of other anatomical compartments. The specimens analyzed in this study came from a clinical study of a single dose of the reverse transcriptase inhibitors tenofovir alafenamide, or TAF, and intracitabine, or FTC, as well as the integrase inhibitor elvitegravir, EVG, boosted with cobicistat, pharmacoenhancer, and a protease inhibitor, darunavir, DRV, is also added. Urethral and gland swabs, as well as blood, urine, and rectal swabs were collected at up to 3 clinic visits between 2 and 96 hours after dosing at the Hope Clinic in Atlanta, Georgia. Urethral swabs were collected by inserting a polyester swab into the urethra and rotating it for 2 to 3 seconds. Gland swabs were collected by pre-wetting a polyester swab in PBS and then rolling it around the head of the penis as well as under the foreskin if the man was uncircumcised. In the first 24 hours after dosing, FTC and darunavir were readily detectable on most urethral and gland swabs, which you see here at the top, while TFV, the metabolite of TAF, and EVG were rarely measurable on either swab type. For this reason, I'm going to focus primarily on FTC and DRV concentrations for the remainder of this presentation. While we were not surprised that TFV was rarely detected on urethral and gland swabs due to the low plasma concentrations of TFV for people receiving TAF, we were surprised that EVG was rarely detected on urethral and gland swabs. EVG in this study was readily detectable on 70% of rectal swabs over this time point, or over this time course, and other studies have also shown that it's easily detectable in rectal or vaginal tissues. However, in this case, our EVG was only measurable on less than 10% of either urethral or gland swabs. Urethral swab FTC concentrations in blue and DRV concentrations in green peaked 4 hours after dosing and became undetectable on most swabs within 48 hours after dosing. In contrast, gland swab FTC concentrations in blue here on the left and DRV concentrations in green on the right peaked about 24 hours after dosing, and they also became undetectable on most swabs within 48 hours after dosing. Additionally, one of the things that we looked at was circumcision. And most study participants for our study were circumcised, but we did collect gland swabs from 6 uncircumcised men at 17 clinic visits, depicted by open circles here in both graphs. In this limited data set, we did note that a trend towards higher FTC and darunavir concentrations on gland swabs collected 24 hours after dosing from uncircumcised men compared to circumcised men. When comparing ARV concentrations on urethral and gland swabs to those measured on rectal swabs, we note that FTC concentrations on urethral and gland swabs are approximately similar to those on rectal swabs up to 24 hours after dosing, but are markedly lower than those observed on rectal swabs at 48 hours after dosing. DRV concentrations on rectal swabs were greater than those on urethral or gland swabs. We did estimate that urethral and gland swabs were collected an average of approximately 2 and 5 microliters of material, respectively, while rectal swabs collect an average of 40 microliters of material. This difference in collection could account for some of the differences we note here between the concentrations on the swabs between rectal and penile sampling. By comparison of peak ARV concentrations across compartments, we see that urethral and gland swab FTC concentrations peak at 4 and 24 hours after dosing, which is later than peak FTC concentrations in both plasma and urine at 2 hours. Urethral swab DRV concentrations peaked 4 hours after dosing, which is the same time as that in plasma, but is before those in urine. And as mentioned before, gland swab DRV concentrations peaked 24 hours after dosing, which is later than peak concentrations in both plasma and in urine. If we estimate peak urethral fluid FTC and DRV concentrations, seen here in red, based on the average amount of material collected per swab, FTC and DRV concentrations should be at least 4 times or at least 4-fold greater than plasma concentrations, yet more than 2-fold lower than urine drug concentrations. Additionally, these estimates of peak FTC and DRV concentrations are at least 50 times greater than the IC90 for both FTC and darunavir. So in conclusion, we've shown that penile sampling can be used to measure ARVs in the male penile compartment. We were able to examine drug distribution of 4 ARVs across 3 drug classes in both the urethra and on the gland surface. We note that FTC and DRV achieve higher concentrations in the urethra and on the gland surface than TFV and EVG. Peak FTC and DRV concentrations appear to be greater than those in plasma and could contribute to protection of men from penile HIV exposure. We also believe circumcision may reduce ARV measurements on the gland surface, and this is likely due to removal of the mucosal surface that's present on the inner surface of the foreskin. Penile EVG exposure differs from those of other mucosal sites, such as the vagina or the rectum. Additionally, penile TFV exposure is low. This is likely due to reduced systemic TFV that's associated with TAF dosing compared to TDF, or tenofovir disoproxil fumarate. And finally, the methods that we've used here can be used and applied to other evaluations of penile drug distribution for new biomedical interventions, specifically to prevent HIV or other STIs. And lastly, I would like to acknowledge all of our collaborators that work with us here in the DHAP laboratory branch, as well as our collaborators at the Hope Clinic at Emory University and our study participants. Thank you.